Good morning, everybody. I am on the hustle today. I have been running like a mad person. I have worked out. My daughter and my wife have got me busy getting ready. I've gotten a little echo here. Let me make sure that echo. Oh, I think we're good now. Just wanted to come on this morning. Thank you guys for those of you who are joining us. Let me actually, while folks are getting on, because for some reason this live app I can't see who's on, so I'm gonna bring the live stream up on my phone. And then we're going to see if we can't see who's joining us today. If you're on here, I'd love to see you guys. Give me a little hashtag live if you're on live. If you guys are joining on the replay, hashtag replay, and let me know if you're having any troubles hearing anything. For some reason, I'm getting an echo on my end here. So let me, of course, when you want to bring up something on Facebook, it never shows up the way you think it should. All right, there we go. And all right, I'm going to just turn my volume off here. Eric Bender, thank you for joining us. So yeah, if you guys joined me last week, I talked a little bit about some of the science of pain around arthritis. I had talked a bit about, let me make sure I got the right mic on too, we're good. Andrea, thanks for joining. So this week we talked a lot about the science of different things and talked about, some of the nerding out neuroscience. And to me, it laid out some hope that, hey, there's people with arthritis have some opportunities for change. And I think if we can be open ourselves to that and kind of understand the science behind it, we're more willing to engage some people in rehab and be able to give these folks hope and actually show them hope by helping them move better and feel better with their knees. So I wanted to go into a little bit today about the keys around what I feel, and based on research, not just Mark's opinion, and based on my clinical experience as well, and my patients that I work with and their perspectives that I've learned from. And the biggest teacher, I think, from working with folks with arthritis is talking to them and understanding some of their perspectives and asking them after rehab when we are successful, well, what do you think was the big turning point for you? What do you think was, the thing that got you over the hump with this arthritic condition? So we'll talk a little bit about that as well. But I wanted to talk a little bit about, let me just get a few things out of the way here. I want to talk about the first step that I think is important. And that first step is to check our own biases. So we need to be able to understand. And I know for me as a clinician, when you hear that arthritic joint or you see that diagnosis, I think just based on some of the biases and how we are educated and how we've been kind of culturally wired to think about arthritis, that there definitely was a hesitancy to really load folks. I had some biases that, man, this is arthritis. This person's in a certain age group. Are you sure I should be really getting in there and putting load through that joint? The thought is it's a very tissue-dominated issue, and that at that earlier stages of my understanding of it, I thought that the more load you put in, probably the worsening you were going to make your arthritis. And of course, that's the same narratives our patients often come with and the beliefs that they come in with. So, but it's hard as a clinician if you're sitting there like having somebody do a TRX unloaded squat and you're like, man, is this going to go well? Patients read that body language, and I think there's those implicit biases that we carry can really affect our clinical care and our ability to engender confidence, to display the confidence, that contextual architecture on our intervention, to say, yes, I am confident you are safe to do this. I am confident that this is the right exercise for you at this time. I am confident that this isn't going to damage you or make your bone on bone worse. So we have to understand our own biases first off before we do that. Constantine, thanks for joining us. Diane, really appreciate you guys joining us this morning. So yeah, if we have fear and avoidance of loading a arthritic joint, how the heck do we expect a patient not to have fear and avoidance of loading their joint? So I just think that should be common sense, but it is something I think as clinicians that we carry some of these beliefs that we talked about last week, that a lot of the clinician beliefs, and it was more from the primary care perspective, that their beliefs were very negative and that it's inevitable and that there's not much you can do about it and all these different things. So understanding those biases from our perspective and checking them and not letting them taint that clinical encounter by giving negative expectation or negative beliefs from us, that's crucial. And if that's not there, I don't see how you're going to ever have success with anybody who you're trying to rehabilitate with conservative care. And again, we're coming in with narratives that patients already coming in with narratives that are challenging as well. Oops, let me just jot one down here. So that's what I think the first step is. That's checking us as clinicians, making sure that we know where we stand, that we're confident, that we know it's safe to do these things, that we know it's safe to load, that we know it's safe to exercise. If that isn't there, I think we're sunk before we even start. So step two, what is step two? Let me see if I can get it up here. And if anybody's followed me or Modern Pain Care, Jared Hall, some of our colleagues, Ben Cormack and others, Gilletta Beltons and Keith Meldrums and Tina over there in the UK, you have to know your patient's story and their beliefs. If you don't understand where they're coming from, what their beliefs are, what they think about exercise, what they think about things that are going on their knee, their shoulder, their hip, whatever it may be, the joint that they're dealing with, then again, I think you miss the target. You don't even have a target, and when you don't know where the beliefs are, maybe they have very adaptive beliefs. Maybe they're very on board with, yeah, this is arthritis. I know it's normal. Let's get after it. Let's load it. Man, great. That's to me a great sign that we're going to be successful. But if we don't know, if we don't ask, Robin, thanks for joining us. To me, you missed a chance to find some impairments of belief, impairments of cognition around their joints. So asking a patient, why do you think you hurt? Well, I have arthritis in my knee. This is, terrible. Well, what do you know about arthritis? What is your understanding of arthritis? Has anybody ever educated you or talked to you about arthritis? Well, no, I just had a patient yesterday where I asked her this exact question. I said, well, do you mind if I share you some of the things we know about arthritis and some of the things we can do from a physical therapy standpoint? And they were all ears. We talked about it, and it was like, watching her yesterday was a big eye-opening thing. And to me, that's a tragedy, because healthcare, we need to do better than that. We need to do better on the primary care front, and that's why I'm a firm believer that in musculoskeletal care, physical therapy is, and musculoskeletal practitioners are your better direct access point into healthcare, versus getting an image, getting told you're broken, damaged, injured, degenerative, here's your medications and wait, and but you might try physical therapy and see if it's going to help. I mean, talk about setting us up for failure. So I think knowing that patient's unique story and being, again, maybe it's adaptive, maybe it's maladaptive, but giving that story the stage and letting that story take center stage, and then trying to fit our narratives and what we know with the research and experiences to see if we can come together with that patient, take their narrative, take our narrative, and bring it together to have something that's constructive, that can move that patient forward to something valuable that they pursue in their life, whether it be walking, playing with grandkids, whatever it may be for that person. That's another reason you need to know their stories. If this joint wasn't as sensitive, what would this allow them to do? There's your goals. There's the things that every exercise there forward becomes to do that. And that is the narrative that carries forward every time you treat this patient. I try to bring those things up every encounter, like, hey, this exercise is a TRX squat. We're going to start working the squat. What this should help us do is, you wanted to be able to walk upstairs in your daughter's house, to be able to walk up and down to your grandkids' bedrooms. These are a building block towards that movement. One, it gets patients on board and engaged with what you're doing, and they see that it's not just this boring TRX squat. Man, this TRX squat equals me getting up to my grandkid's bedroom. I think it brings more value to it. Probably makes the patient more engaged to possibly do maybe a wall squat at home, or something that is similar that they're doing at home to start building up their load tolerance of their knee. So Yones and his group over in Belgium, I think, have really been probably I don't want to say the first group, but have published a lot more about cognition targeted exercise. So what do you think about doing this squat? What do you think about doing this overhead stretch with your arthritic shoulder? What do you think about us doing this exercise where we're going to have you, do some sidestepping with your knee? Those are questions I think you have to be asking a patient to make sure. Here, Louis Gifford talks about top down before bottom up. If top down is like, oh my God, this is bad for me, and you don't know, and you're just trying to just force exercise upon that patient, to me, you don't have a great chance of success. Harold, thanks for joining us. Daniel, really appreciate it. So top down, can't emphasize that enough. Knowing your patient, their story, their beliefs, and what's happening. I mean, we don't obviously perfectly understand how those thoughts and beliefs materialize themselves in a possible increased sensitivity in a hip joint or a knee joint. But I do think we see enough with catastrophization, fear avoidance beliefs, and the research that relate that to poor outcomes to think that, man, that's important stuff that we need to know. and we need to understand the cognitions of our patients when we're engaging them in exercise and asking them. I ask patients, what are your thoughts on this exercise? What do you feel? Do you feel like this is a good one for you or not? I mean, I just think that's a simple conversation, but it's something that can really give you an understanding of top down what's going on when they're doing everything. I think too often we assume the patient's on board and this is the greatest exercise on earth because of course we took our functional exercise course level 18 and we're ready to just unleash the world of amazing exercise on the patient, which I joke with, but of course it's a crap exercise if the patient isn't on board here. And it can be a great exercise if you get them educated and explain why you think it is a valuable part of their program to help them reach their valued goals. So I think, again, that can be something that can be very helpful. All right, so that was step 2. The other thing I have really found helpful when you're working with folks with arthritic change, and that's their diagnosis. Again, remember last week we talked about a lot of these folks coming into our clinic with that diagnosis. It's just kind of, they get slapped that diagnosis because they have pain. And a lot of times in primary care, although I don't see it as much in my neck of the woods, it's that the primary care doesn't order an image or anything. They said, you got arthritis in your knee and go on. And then we're seeing the research shows that a lot of these people with that diagnosis coming into clinics, they don't have any of the imaging findings to support it even. So again, I think we have to know that, some of these diagnoses maybe aren't as ironclad. And again, arthritic diagnosis, again, I joke with patients of degenerative scalp disease, and we talked about last week, is the same thing we're talking about our joints, where it's probably natural aging. Of course, for me, maybe a little earlier than others, but it's all good. The bald head is doing all right. But anyway, to get back to the topic at hand, how to execute exposure therapies and behavioral experiments. Any of you guys who follow Peter O'Sullivan's stuff, he's a master at doing behavioral experiments where you're really constructing clinical scenarios where patients who think, man, my knee's going to be destroyed if I squat or do different things. I like it personally in my practice, the TRX. The TRX allows you to do some unloaded things, allows them to maybe load through their heels versus their toes, which can decrease loading force on the knees and do different things that I've had numerous patients where once they see that, they do a little squat where they're going through their heels, they're maybe loading more posteriorly into their hip, and all of a sudden their squats markedly improve with minimal to no pain, and they're like, oh my God, that I just squatted. Jump on that. I'll say, well, what do you think? We just put some load through your knee, obviously less than what they do when they're squatting, maybe with that more anterior onto the toes type squat, the more sissy squat type squat. That's an opportunity for them to start challenging their beliefs. Like you had mentioned, Corey Blickenstaff's probably one of the best in our profession in physio at kind of teaching this and giving you guys some understanding of how to do it. But have them make a prediction. What do you think is going to happen if we have you do a squat with your knees? Oh, my knee's going to, be in shambles for the rest of the day. I'm going to be in trouble. Robert, Philip, thanks for joining us. So yeah, understanding that prediction, and then you do an experiment. You say, well, let's see. What are your thoughts on us trying a little bit of a squat here? I think based on my examination, I think you're going to be able to do this, and we're talking about sensitivity, not damage. This is obviously, you've maybe laid some foundational work before this. Let's have you try it. And you give them the squat, and you need to exude your biases. If you have any fear avoidance of arthritis, you need to check that at the door and be very confident that this is the right thing for you today to do. And then you have them engage in the squat. And then again, you see those patients like, whoa, what just happened there? And those are the times that you just jump into, well, what do you think happened? You told me that if you do this, your knee was going to have, just a horrible response. It looked great from what I see. That was a great squat. And some people even are a little sensitive with it. I'm not saying everybody like magically it's 0 out of 10 and life's hunky-dory, but they can do it. And it's not, their knee isn't bad, and they can walk around and, hey, it's not bad. And again, that just can lay some groundworks where you have them structure a conversation where they challenge those beliefs. Like, what do you think? Your thoughts was going to be this. Looks like you're doing well. Does it seem like it produced that response that you thought it would be? Well, where does that leave you when it comes to arthritis? Do you think that we're safe to engage, or do you think, where is it? Where are your thoughts with this? And then you see where they're at, and you can kind of start nudging them forward into some of these things. But behavioral experiments are just, maybe setting up ways where you can do some biomechanical tweaking or different things. You have them squat with a band on their knees pulling out, or you do maybe some biomechanical tweaking. That's a symptom modifier that allows them to do a squat, or you do it, like I said, the TRX symptom modification technique, and you show them that you confront them with their abilities, basically. I think Greg Lemon's probably the one that most pioneered that. And you let them kind of prove to themselves that their knee is capable. Obviously, your education gives them hopefully some hope and some thoughts, and your behaviors around their knee and or their shoulder, whatever it may be, give them hope or show them that you're confident in it, and then you let them build their confidence. But again, they have to be willing to engage with it, and that's where even some acceptance and commitment therapy techniques and talking about willingness. Are you willing to pursue walking upstairs and do different things if it means being able to play with your grandkids, even though it's not going to probably change what your x-ray looks like, even though it's not going to probably change what your MRI looks like. And that's a very, Bronny would probably scoff at my rendition of ACT there, but that's kind of the gist of it as far as being willing to engage in valued activities and not be fused to the thought that they can't proceed on unless their knee's fixed or their arthritis is gone or whatever it may be. So those type of techniques, huge. I think knowing how to conduct those can be a very powerful tool in your treatment, and it doesn't need to be anything fancy. It's basically setting up clinical scenarios, and there's skill to it. I mean, it's challenging, but setting up clinical scenarios that are kind of in that just where the patient can start seeing success, and you start confronting them with their abilities, and hopefully getting some cognitive restructuring of their thoughts around what's going on and what their future possibilities are. And again, treating probably top down just as much as you are bottom up when you start doing these type of exercises with people. All right, I already talked a little bit about this, and this is kind of the last piece that I'm going to talk about today. And this is not by any means an exhaustive list of stuff that you can do with somebody with arthritis, but these I thought were probably the biggest keys to working with folks with arthritis. And before we even get into this step, recognize too that there are true people who have severe arthritis, and despite our best efforts, I'll still say, hey, let's give your joint a chance to do better. But I still do occasionally refer a patient on for further, like a knee replacement's okay. It's not the devil. Biomedicine isn't the devil. Now, it does get overutilized, and I think we don't even get given a chance to be successful with patients based on our cultural beliefs around arthritis and what primary care tends to give to a patient as far as thoughts and beliefs and the education that they give of this doom and gloom scenario with arthritis. We do know that there's about 1 in 4, if not 1 in 3, of folks that have these replacements that don't do well. And we talked last week about some of the pain profiling that we can do to start recognizing these people who show significant nociplastic changes, decreased pain modulatory capacity, all these different things. So again, I don't want you to think that I am telling everybody that regardless of if you have arthritis or not, everybody's going to do successfully in conservative care. I do think we should get a heck of a lot more people in conservative care and be given the chance to, and we need to start working with our primary care physicians and practitioners and physician's assistants, orthopedists, all those folks, to start giving us a chance, to not sink us before we start by giving patients these thoughts of, well, you can try physical therapy, but it's just a matter of time before you're going to need that joint replacement. I mean, that just really grinds me when I get that narrative coming into my clinic, because again, talk about making my job harder, or our job harder, I should say, just doesn't help. But again, cognition targeted exercise, probably already talked a little bit about it, but again, when you start engaging patients in the clinic with everything you're doing, treadmill, bike, TRX squats, clamshells, whatever it is, what are their thoughts around it? Do they feel safe to do it? Do they feel like this makes sense, how this is going to help them towards their valued goals that you've established when you heard their story and you really ingrained their valued goals into everything you're doing in the clinic, and tying everything you're doing in the clinic to that. So what do you think about this exercise? Do you feel this exercise is safe for you? Do you feel this? Can you see how this exercise may be helpful in you getting to your walking upstairs to your grandkids' room, or walking down to the lakeshore? I just had a patient to be able to watch their grandkids play at this lakeshore area in Minnesota. I think, again, it all needs to be understanding what is best to our ability. What do we know is going on from a cognitive beliefs and structuring around their activities, by knowing what's going on top down. We know that nociplastic changes and all these things that go on in the central nervous system can really impact, sensitivity and cognitive or pain modulation abilities. Some of those central pathways of facilitation versus inhibition that can come down into the spinal cord when we talk gate theory and different things. But man, maybe we can influence those by understanding the patient's cognitions. And if you see that the patient's like, oh my God, this is bad news if I do this, then you pump the brakes. You don't just push through you have a conversation, you talk about it, and you say, and if they're still absolutely not, then you find it. There's a million ways we can load a knee or a shoulder. I mean, don't get caught up on one way of doing it. Be flexible to the patient, fit you to the patient, not fit the patient to you, would be the biggest thing that I would say with that. But anyway, what I want to say, I'm going to close it off with that. But if you guys can do me a huge favor, pound on the like or love button if you found that this talk was the least bit helpful for you, or pound the angry button if you found like, man, what a waste of my time here talking, listen to Mark blab about arthritis. Other thing you can do is take a look at our complete patient experience page and like that baby, because we're going to have a awesome conference here in November in Phoenix that's going to pretty much take uh, everything we're doing in clinic or what we're talking about here, but we're going to take it full circle. So when we talk about cognition targeted exercises, wouldn't it be nice if your front desk actually understood what those patients' beliefs are? They actually got it on the front in the first phone call. That's what Jerry Durham's going to teach everybody. How do you have your front desk be your best, ability to cue you up for success, so you know where the patient's at from some cognitions and beliefs around their condition, what their expectations are, so you can kind of have some targets to aim at when you start getting in clinician. If I know a patient's coming into my door, into my clinic, and the front desk is queuing me up, say this patient feels like she's going to need surgery, she thinks bone on bone is the worst thing ever, and that she's going to, this is a waste of her time, then I know I got some work to do, and I'm going to really try to structure my exam and generate some hope, set up the contextual architecture to show her that we're able to move forward with things, and maybe do some behavioral experiments to prove her wrong, to let her prove herself wrong, and not maybe me saying, well, you're wrong, that's arthritis, is just a bunch of degenerative stuff that's like my degenerative scalp disease, and you're not right. So just that ability to have your front desk on board. And then we're going to talk about manuotherapy. I'll talk about how we can use that in a very science-based, evidence-informed framework to apply to maybe an arthritic joint, and kind of understanding some of the neuroscience behind pain physiology, what happens when we manipulate, when we mobilize, and all that stuff. Ben Cormack's going to be with us. He's going to be talking about exercise and how we can maybe tie all this stuff together and engage with exercise. And then Jared's going to talk about education and communication in that experience. How do we take this whole manuotherapy exercise front desk and just really mesh a good communication strategy from the front to back, and even after post-discharge, Jerry is going to talk about, so we can help with really helping patients live well and stay living well, and stay away from expensive invasive interventions when we're seeing that they have a lot of hope to do better otherwise. But again, patients need an advocate. I think we can be that when it comes to arthritis. So other thing you guys can do for me, share this thing. If you found it helpful for you guys, share it around to some folks that you think might help, or it might help to better help them help their folks in arthritis. Don't have to, but I'd appreciate it if you guys did. The more you shared, Facebook's algorithm is kind of like, man, it only shrinks it to a few folks in this group. If you share it around, it gives opportunity for other folks to maybe glean some pearls of wisdom. Hopefully they feel like I shared some. So I just wanted to thank Eric, Mario, Michael Haley. Good to see you, buddy. Hope we'll see you in San Diego again next go around. Anthony Destano, thanks for joining us. You guys have a wonderful rest of your Thursday. I will be on every Thursday. Ideally, we might change the time, but for right now, it's going to stay at 7 a.m. Next week, I'll let you know what the topic is going to be. We'll pick it up. We're going to probably have some guests coming in as well to start talking about some other topics that are going to help you guys in your practice. So have a great day.